Hello and welcome to our channel. Today we're discussing a critical finding in cardiology. Among patients with recent myocardial infarction or MI and increased ventricular ectopy, the use of antiarrhythmic drugs suppresses ventricular ectopy but increases mortality. Let's explore the details. Post-MI ventricular ectopy's significance varies with the timing of the arrhythmia. Early ectopy within 24 hours is likely related to reperfusion ischemia and is less prognostic. However, non-sustained ventricular tachycardia, or NSVT, occurring more than a week after an MI significantly increases the risk of sudden cardiac death, especially within the first 6 months. In the 1970s and 1980s, studies aimed to determine if suppressing ventricular ectopy post-MI could improve outcomes, but these were inconclusive. The Cardiac Arrhythmia Suppression Trial, or CAST-1, provided crucial insights. This multi-center, double-blind, parallel group, randomized, placebo-controlled trial included 1,498 post-MI patients with increased ventricular ectopy and depressed left ventricular function. Patients were randomized to receive either encainide, flecainide, or placebo. The study was stopped early due to increased mortality in the antiarrhythmic groups. Who were the patients included in the trial? They had experienced an MI in the prior 6 days to 2 years. They had a mean of 6 or more asymptomatic premature ventricular contractions, or PVCs, per hour on an ambulatory electrocardiogram monitor. Their left ventricular ejection fraction, or LVEF, was less than 55% if the MI occurred within 90 days, and less than 40% if more than 90 days had passed since the MI. Patients were randomized to receive either encainide, flecainide, or placebo. Initial open-label titration identified patients responsive to PVC and NSVT suppression. Flecainide was not given to patients with an LVEF of 30% or less. Responding patients were then randomized to the trial drugs or placebo. Now let's discuss the outcomes. The primary outcome was death or cardiac arrest due to arrhythmia. The results showed that death or cardiac arrest due to arrhythmia occurred in 5.7% of patients on antiarrhythmics versus 2.2% on placebo, with a relative risk of 2.64 and a number needed to harm of 29. All-cause mortality was 8.3% with antiarrhythmics versus 3.5% with placebo, with a relative risk of 2.38 and a number needed to harm of 21. There was also an increased non-arrhythmic death due to MI complicated by cardiogenic shock, occurring in 1.5% of patients on antiarrhythmics versus 0.4% on placebo. Following CAST-1, CAST-2 also showed increased mortality with antiarrhythmic use. This led to a significant shift in treating MI patients. Encainide and morisazine were withdrawn from the market, and Class IC antiarrhythmic drugs became contraindicated in patients with coronary heart disease. Modern guidelines from the American College of Cardiology and the American Heart Association, or ACC-AHA, do not recommend antiarrhythmic medications in acute coronary syndrome care. For those interested in diving deeper, here are some further readings and references. Bigger et al. Prevalence, Characteristics, and Significance of Ventricular Tachycardia in Acute Myocardial Infarction. American Journal of Cardiology, 1986. Amsterdam EA et al., 2014 HAACC Guideline for Non-ST Elevation Acute Coronary Syndromes, Journal of the American College of Cardiology, 2014. Ogara PT et al., 2013 ACCF-AHA Guideline for ST Elevation Myocardial Infarction, Circulation, 2013. Thank you for joining us today. If you found this video helpful, please like, share, and subscribe for more content on medical research and clinical guidelines. Until next time, stay informed and take care.